Chairman Franks and distinguished members of the subcommittee, I'm Byron Calhoun, and I serve as a professor and vice chair of obstetrics and gynecology at West Virginia University in Charleston. I'm very pleased to have this opportunity to testify on the current issues, and I'm very glad that I'm able to speak for this consideration of the District of Columbia of the Pain-Capable Unborn Act. As I understand it, this would limit abortion at 20 weeks fetal age, which is 22 weeks of LMP, which has already been discussed. Objections have been raised about this legislation, saying that it should be permitted after 22 weeks because it's necessary and appropriate and a way to deal with a fetus with significant physical anomalies, including lethal anomalies, and I do not agree emphatically. There are other ways that are far more humane for both the parents and the child. My training, as noted, has been in maternal fetal medicine, which is the care exclusively of high-risk pregnancies, and this includes care of pregnancies, literally hundreds, with lethal anomalies. In my 25 years of practice, I've never found it necessary to terminate a pregnancy to save the life of the mother for an anomaly. I've had to deliver multiple patients prematurely and had babies die from prematurity, but I have never had to take the life of a fetus to save the mother's life. In the cases of fetal anomalies, we advocate patients be offered the option of perinatal hospice, which is a prenatal diagnosis of the terminally ill neonate in utero, perinatal in utero, leading to perinatal hospice as a continuum of end-of-life care. Prior to the development of this concept, counseling provided parents with basically one option only, and that was assumed to be abortion, and offered no other alternatives. These were well-intentioned desires to spare the mother and her family, to solve the issue, to have the obstetrical provider do something, and perhaps deal with the discomfort they may have with bereaved parents, and perhaps the ill-advised avoidance of complications of pregnancy, and also an unsubstantiated concern in maternal mortality. Research in grief actually has shown a different picture, and in fact there have been several studies show that there is actually prolonged and significant grief after the termination of a wanted pregnancy. With regard to the fear of maternal mortality, the rates with induced abortion at the time we're talking are about 9 to 10 per 100,000, and the rates for pregnancy death overall are about 10 per 100,000, and essentially the same mortality rate without an increase. To do this, we basically looked at Kubler-Ross's understanding of death and dying, and what we've done is support and give these patients an opportunity to be with their children in their pregnancy. We've used Saunders' idea that these people feared abandonment, and what we provide then is a high-touch care, not necessarily high-tech. The emphasis is on affirming by care for these children and their families and allowing them to have the support of medical, emotional, and spiritual needs of their family through a multidisciplinary team. The emphasis is in basically not a type of care, but basically in the amount of care, the focusing beyond the family and not on the fetal diagnosis. The family is placed at the center of the care, and they're allowed to work through the grief and the death of their child. Hospice preserves a time for bonding and loving and loss. Amy Kuhlbeck, writing Waiting with Gabriel, said, with her son who had a fatal anomaly, "I know some people assume that continuing a pregnancy with a baby who will die is all for nothing. But it isn't all for nothing. Parents can wait with their baby. They can protect their baby and love their baby as long as that baby is able to live. They can give that baby a peaceful life and a peaceful goodbye. That is not nothing. That is a gift." One of the major clinical issues in hospice, as I noted, was fear. Patients really fear that they're going to be abandoned by their health care providers. They're also worried about pain, as was elegantly described by Dr. Malloy. With the ability to have perinatal hospice, we're able to develop birth plans, pain intervention, oxygen feeding medications, all the care that a normal neonate would have with the parents if they so desire, through a multidisciplinary and easily accessible hospice team. We also provide support for anticipatory grief, and we often share the realistic outcomes of this pregnancy with the child with the lethal anomaly. We usually validate the diagnosis of delivery, and we allow these patients to spend a maximum amount of time with their children. We have published 2 series in this case with children with lethal anomalies and found that if offered this implicitly, between 70 and 85% of patients will choose perinatal hospice. And in spite of what has been previously stated, there is a huge grassroots movement for this. There are now 125 perinatal hospices in 34 of the 50 states, and there are 13 international hospices. What has started as a small, simple idea to promote patient-centered choice and humanity honoring care has blossomed into a national and international movement for compassionate care for families. We look forward to the day when all patients will be allowed to be just parents and love their children for however long they may tarry.